anytime injection goes in, it can obviously for some have healing properties, but until your nervous system is attached signal-wise to whatever tissue you're trying to heal, there's a strong possibility, especially if it's not built into habits, that you're going to re-injure
For
yourself and it's
sure.
getting worse.
Most people don't heal their injury fully
Mhm.
before they feel they can get back to 100%. Now, what either happens is, number one, the pain goes away, so they think it's healed.
Mhm.
And just like Doc said, it takes a lot longer than you think.
Yeah.
So even after the pain is gone and you feel like you're doing well, continue to do these and practice them.
When you first off, let's say it's an acute injury, ideally you'd want to start off with isometric, so just squeezing the muscles around it. So for the Achilles tendinopathy, just trying to squeeze your calf, quad on and off, maybe 5 to 10 seconds throughout the day. Whenever you remember it, or set a timer in your phone every couple hours or so. So I do the calf, and then I also look to squeeze and grip the ground. So then we're addressing above and below.
When we take and we inject steroids into that setting, it actually freezes or stops the healing process. So now your body is not eating away that nucleus pulposus, that jelly-like substance, and you're basically shutting off the inflammation part of how we heal.
Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Welcome back, everybody, to the Functional Code, episode 41. Doc and I are super excited to bring this pod to you guys today. We're going to be talking about the guidelines on regenerative medicine treatment for chronic pain. So what we're going to do today, Doc and I are going to break down, we have a lot of research here for you, and we're going to break down each and every bit of it so that you understand what it is that we are going to be preparing for you. It's going to be very clear. You're going to understand the evidence itself and how high of quality it is. And then we're also going to break down conditions that all of these regenerative medicine treatments can help with. What are the best ones? What are the ones that maybe have more research that are needed? And we're going to go from there. So thank you guys so much for tuning in today. We're not going to be able to promote this on YouTube. So this is just one we're going to have you guys hopefully share with anyone that you feel is beneficial, because we want to make sure that everybody understands what is the best when it comes to this field of medicine and what can we do to help you guys. So thank you so much. As always, I am Dr. Addy.
And I'm Dr. Jace. And yeah, when Doc brought some of this research to me and we started discussing it, this is a perfect way to break down in terms of the level of evidence and the quality of research, from whether it's randomized control studies, which are incredibly high quality research, versus other aspects of like clinical experience, experts, clinical observations. Even with that, is some pretty awesome research. Today we're also going to be going over the degree of recommendation for each of these, whether it's PRP, stem cells, adipose tissue, whether it's BMAC, which is bone marrow aspartate concentrate. We're going to be breaking down all of these therapies and how they can affect, whether it's elbow problems, whether it's feet problems, and how are some of these therapies used from a research standpoint and with the evidence itself. This is going to be a fun one. Doc, let's dive into some of on how we qualify and how are some of the levels of research brought to fruition.
So the main paper that we're going to be using to explain this to you guys today is going to be shown in the headline. It's a huge consensus report that was done by multiple providers, and they really just brought together hundreds, I'm sure even more, it might even be thousands of studies, and they graded basically the information that they included in the report. So they have a strength of the evidence, meaning the research quality was really high, or it was, I wouldn't want to say low, because from a level 1, which is the highest, this would just mean that it's a strong support or a high quality trial. So the trials were done really well, meaning that the research is even more valid. versus level 3, which is their lowest level of evidence. But their lowest level of evidence was reports from expert committees. So that actually still is relatively high quality. Not that it's more than a level 1, but it's still pretty good. So their lowest standard, would, in my opinion, was actually still pretty good. So it went from a level 1 to a level 2, and there's 3 sections to a level 2, and then there's level 3. So that's the evidence levels that we're going to be talking about when we bring up certain research. And then there's a degree of recommendation, meaning how strongly do they recommend, based on the evidence, that you can do said therapy for said condition.
Well stated.
And that goes from a grade A all the way to a grade D. So grade A is it's strongly recommended with good evidence that it's effective and the benefits clearly outweigh the harms, which I like that that's how they stated it.
Agreed.
And then the grade D is the lowest, which is it's not recommended because the evidence shows it's either ineffective or the harms outweigh the benefits. So it's not that they didn't see change, it's just that they feel the risk is not as worth as the reward, which I like that they said that too. Because there are some times where we know we might get a good positive change, but there might be some drawbacks to it. We're gonna do our best to explain each portion of the research that we talk about using these scales. And then of course, Doc is gonna do a great job of just giving you all of that in the headlines, so that way you don't have to. We might just talk more about the meats and the bones, and then you guys can go back through and see what the grades are. We don't need to talk about all of that as we go through.
So I guess, Doc, PRP, platelet-rich plasma. If you guys don't know, in terms of how this therapy is done, just a broad, brief overview. Blood's taken out of an individual, spun, platelets are taken out, and it's brought and put back into the person. So, Doc, I know as we break down some of this PRP and with some of the research, we're going to be breaking down anything from lateral epicondylitis, medial epicondylitis, Achilles tendinopathy, plantar fasciitis, rotator cuff, knee, osteoarthritis, hip. There's a lot of stuff. I'm sure there's even more than what we have here
For sure.
in terms of shoulder, lower back, SI, disc. But let's start breaking down each one of these and where are some of the better treatments based on the research.
Yeah, and before we started, I mentioned to Doc, I think also for you guys listening, he and I are going to take each condition, and we're going to obviously talk about the effects of each biologic, but we're also going to throw in our expertise, clinical experience on treating these conditions. We're going to give you one gem from each of us for each of the conditions as well. This is just our way of saying, yes, these biologics are either super effective or they have some more work to do, but we know that this is not just a cure-all. So you're going to still need to do other things on the side for the best effects. And Doc and I will each throw our gem in there on what are some other ways to manage these conditions. So if you're listening and you have elbow issues, ankle, foot, hip, knee, listen up, because we're going to throw some other gems on top of what we're going to give you today, too.
Love it.
So first and foremost, the research started with tennis elbow or lateral epicondylitis. Now, that's, before we jump in, it's just the lateral side of the elbow. You usually get that from, the reason it's called tennis elbow is just from the kind of whipping motion, whether that's forehand or backhand. And it can actually come from a lot of, we usually don't, it's funny, we don't see a lot of patients playing tennis coming in and having that pain. It's usually patients who are gripping a lot, they're working with their hands. Maybe it's desk workers who are keeping their forearms fixed in a certain positions for long periods of times. If you are listening, office workers, trust me, this does relate to you. And they looked at the research for PRP injections for tennis elbow, and it was associated with superior long-term relief. And long-term, they graded from 3 months to even 2 years that they found in some studies as far as the relief that they had compared to steroid injections. We know the first injection that most receive when they have pain in a modern medical setting is going to be steroids. And this is why we're bringing this to you today, because we're finding that there are better alternatives. And also, steroids are degradative in nature. So when we continue to get more of them, it starts to break down the soft tissue. And that's what we're trying to avoid. So for sure, it is highly recommended comparative to steroids for tennis elbow, PRP is. And also with the PRP injections, I also want to note too, Injections, and maybe this is the first time I'll bring up my gym for tennis elbow.
Perfect.
There was a study a long time ago, I think over a couple of years ago, that I read that really looked at, I think, 10 or 15 different injections for epicondylitis.
Mm-hmm.
And they didn't see a lot of significant change in all of them. And I think PRP was included. Now, in this study, yes, PRP was vastly superior to corticosteroids. But if we take a look at the actual research, it doesn't give you the real benefits that you're looking for from what they saw in their research. Now, what that means for me is you can use injections and you might find relief.
Mm-hmm.
However, when I first start treating lateral epicondylitis, I like to start maybe less invasive, and then maybe we'll have to end with injections.
Yep.
So for my first gem, if we're having such pain in the short term, a typical elbow brace, a Chopat brace, is where I start. This is usually a great way to just tether off the tendons that are inflamed. You're able to use it with a lot less pain. And once we can get some of that inflammation down from the overuse, you'll actually find that to be even more beneficial, and you may not need injections. Doc?
Absolutely. No, that's a good point. And even with some of the PRP injections, like other therapies are absolutely needed along the same time, because anytime injection goes in, it can obviously for some have healing properties, but until your nervous system is attached signal-wise to whatever tissue you're trying to heal, there's a strong possibility, especially if it's not built into habits, that you're going to re-injure yourself and it's getting worse. But I really like the point that you brought up, and we've used it with a number of patients in terms of like tethering off for that brace, because then it puts more pressure on other nearby structures, if we will, which then accelerates the healing aspect. So no, really good points. As you go through, and I'll probably bring some of this up when we go to the medial epicondylitis, but there's different types of training that you can do, whether it's for ligaments, tendons, joints, muscles, and some of that has to be added into the equation in addition to these PRP injections. But you guys may have known in the past that most medical doctors, or in our medical system, there's only so many tools that they have in their tool belt.
For sure.
So when they look at helping an individual, especially if it's covered by insurance, it's a world we live in right now, at least in America, they want as cost effective as possible, and they want the pain gone.
Yep.
A lot of times they don't think about the long-term effects, or how some of the steroids can break down some of the soft tissue, and it leads to more problems down the road from there.
For sure. Yeah, absolutely. I really hope we can change the narrative when it comes to pain injections. I've always stated, ever since I started working with PRP, that it will one day replace corticosteroids. And I hope that happens sooner than later, because just of how it's just gotten to a point now where if we don't have to worry about the risks of using steroids long term, which for those of you who don't understand, but even more than 3 steroid shots a year you can end up with increased chance of muscular tendinous tear, cataracts. It can change your blood sugars. There's a lot of things. So we don't have to worry about that, and we still get the same results. I don't see why we're not using this more frequently. Next up is golfer's elbow, which is just the other side of the elbow. And recommendations: it can provide long-term relief compared to surgery, or tenotomy, which is just they're removing tendons. Now, corticosteroids are not recommended due to their short-term, even though that there's short-term relief, but there's possible potential tendon damage, and that was what the report shows. Just like we just mentioned, that's what they're stating here. There's no reason to do steroid injections at that area, because it's only possibly going to damage the tendon further, even though you're getting pain relief. So, Doc, what are some ways that you can also manage medial epicondylitis, and how do you approach it?
Good point. So when you look at whether it's pain in the elbow on the inside, outside, for medial epicondylitis, that's going to be pain on the inside portion of the elbow. And this is going to be a lot of rotation of the wrist, repetitive use, whether it's going back to the episode on delivering mail, on constantly either gripping down and then putting into the mail into different slots, or computer work, like all this stuff, that it adds up over time. These are repetitive use injuries that either, one, you have to have rest, or two, you have to have a certain specific type of therapy. In terms of addressing the specific rehab and therapy thereof for any of the epicondylitis, you first want to start in a short position. So if those that are listening and not watching the video, if you want to start with your elbow bent, arm inwards, holding the opposite side of the arm and then trying to resist with your other arm as you bring your arm from bent inwards to straighten outwards as you're opening up your hand, that can help significantly bring a shorter tissue and lengthen it. And the key part to this is you want to start short, muscle contraction, and long, so eccentrically. And that will help bleed energy to the tendinous properties. You want to start off a little lighter in terms of the intensity when you first start, in terms of how strong or how much you flex and or how slow you go through this process. So that would be one for the medial epicondylitis. Now, let's say we wanted to go for the lateral one. Now, there's a couple different ways. Usually that works really well if you want to do a pin and stretch. It's a mixture of muscles and tendons. So if you put pressure on the outside bone of your elbow, move downwards towards your thumb, bring your arm outwards bent, and then from there, trying to bring your arm inwards and straighten it. As you go through, you want to flex your hand in and then relax everything.
Nice.
So again, for those that are listening, bent elbow, try to bring your hand outwards, put pressure of your opposite hand below the outside bump of the arm that is bent. And then from there, very slowly bring your arm inwards and straighten it, and then flex your wrist to your body.
Right.
Now that will be one that you can start to address it probably outside of the repetitive use type of movements that you find yourself in. But both of those two will help significantly for the tendinous properties, and then work on that over time. If you guys want other recommendations in addition to that, you can go through what's known as elbow workspace or elbow cars, which you start your arm straight, trying to rotate your palm outwards as you go bending your elbow all the way up. When you can't bend your elbow anymore like a bicep curl, bring and rotate your hand so it's facing away from you. And then you straighten it very slowly from there. And you can go clockwise, counterclockwise. So that can bleed some of the blood flow to the edges of the joint. So it can also help for the rehab properties as well, in addition to this PRP therapy as well.
Absolutely. And for those curious on how often they should be doing that, even once an hour, do a pin and stretch car.
Yep.
Both will take 20 seconds.
Absolutely.
Do that every hour, maybe at your desk or however. And frequency, is that
I
good,
like
do you think?
that. And we can go anywhere from 3 to 5 reps. The key for a lot of this is going to be a mixture of rest, but then going through, and you're going to know if you're pushing it too much. It's going to suck a little bit, but you don't want a sharp pain. And as you go through, even if it's just a very nice, light and easy, just going through the movements, that'll help significantly
For sure.
as well. So
Yeah,
point.
well, that's awesome. So again, for medial epicondylitis, PRP can help, but for sure, steroids are not recommended comparative to. Next is Achilles tendinopathy. So with Achilles tendinopathy, this is the long tendinous structure that is behind your ankle heel, and it connects to your calf muscles. Now, the evidence is inconsistent. Some studies suggest no difference between PRP and saline injection. Saline was just probably used as the control, which is just salt water. So if you are having those issues, you might want to look into different therapies. It also showed that prolotherapy, which is just usually just dextrose water, or corticosteroids, showed varying results. So it's not those are not recommended either. Also, I would never inject steroids into a tendon. I'm surprised. I would even say it is definitely not recommended.
Yeah.
So with Achilles tendinopathy instead, Doc, where should they be first thinking about as far as improving that?
Yeah, that's a good point. So when you look at the Achilles, you want to first start off with looking at your foot, and does it pronate or round downwards on the inside portion? Because automatically that'll pull tension from the heel, thus lengthen the Achilles tendon itself. So if people even have foot pain, you definitely want to start by looking at the muscles of the calves, but just as equal as the foot itself. And this is where, when you look at, and I don't want to call out any profession, but other professions that look at more of the muscle aspect, there's certain things for some providers that they don't look at the whole area above and below, whether it's top down, calf, knee to the Achilles tendon, or whether it's the foot bottom up to the Achilles tendon. You have to look at all of the whole leg for this condition itself, because when you're walking on a consistent basis, the pressure against gravity in each step as you go from your heel, push off your toe, it all puts pressure not equally on certain muscles, but if you have the same type of gait or how you typically walk, that then can lead to overuse injuries, thus some of these tendinopathies.
Especially if you're not walking appropriately.
Yes.
For sure.
Yep. So I would probably go back to the podcast we did on the foot, ankle, knee.
Yep.
We have a lot of stuff on gait, so you can dive into that there. But in terms of specifically for the Achilles tendinopathy, there is a study that they did known as the Alfredson's protocol. It's where they started patients when pretty much almost like a calf lowering instead of a calf raise, but the focus was on lowering. So again, a lot of this goes back to the eccentric work, bleeding energy into the tendinous properties, and that's where you pick where some of the research is and can that benefit other areas. And for this, and from clinical experience and other research, any eccentric work bleeds a lot of energy into the tendons. You want to start off by slower in terms of how you progress this, because as you go from either a short to long position or a long to short position, between the tissues, especially the fascial plane, it leads to a little bit more friction. But in terms of when you first off, let's say it's an acute injury, ideally you'd want to start off with isometric, so just squeezing the muscles around it. So for the Achilles tendinopathy, just trying to squeeze your calf, quad on and off, maybe 5 to 10 seconds throughout the day. Whenever you remember it, or set a time on your phone every couple hours or so. So I do the calf, and then I also look to squeeze and grip the ground. So then we're addressing above and below where that tendinopathy is. As that becomes easier, as some of the tension, discomfort starts to die down, if there's swelling, there might be some more tears, so watch for the swelling as well. You maybe elevate from there, or your leg. But as that becomes easier, then you want to go from lower. And so then you would start off in terms of a calf raise, maybe staying on a stairs or stack some books, and then lower your heel down to the ground as slow as you possibly can. Reset both feet, come back up the top, maybe more pressure on that one foot that you're dealing with, and 1 foot at a time, slowly lowering your body weight down to the ground. And that's where you want to spend a little bit of time with you. We're talking anywhere from 6 weeks or so, it could be up to 8 weeks in this time frame. Pain will start to die down. Walking should become easier, but you still want to pay attention even as the pain dies down to still continue working on these type of exercises for a good 6 to 8 months, even down the road as well.
Yeah.
Because anytime you have an anatomical injury to a tissue, whether it's tears, fractures, it's going to leave that change because of certain areas will not necessarily heal completely. Some, there's a strong possibility, but others not. Depends on where in the body and lifestyle factors, bunch of stuff from
For
there.
sure.
But yeah.
So the only thing I'll touch on is, for those curious how often, what do you think, Doc? 5-10 reps every few hours, a few times a day, something like that?
Yep.
And then the other part was, most people don't heal their injury fully before they feel they can get back to 100%. Now, what either happens is, number one, the pain goes away, so they think it's healed. And just like Doc said, it takes a lot longer than you think.
Yeah.
So even after the pain is gone and you feel like you're doing well, continue to do these and practice them. This is how you will prevent anything from happening. Nothing's ever prevented, but pretty close to.
Yeah.
Way less of a risk than if you were to just quit after the pain stopped.
Yeah.
And those are the only things that I just wanted to touch on too with that. But no, that was great. Yeah, that was awesome. Let's see, number 4, plantar fasciitis. And plantar fasciitis is just inflammation of the fascia on the bottom part of the foot. It's usually right by the heel, closer to the arch. Sometimes you feel it on the lateral side of the heel, but most of the time it's on the bottom of the foot. It can be due to many different things. We touched on a lot of risk factors that can contribute to plantar fasciitis in our foot podcast. The main ones are weakness of the feet, proper gait, or constant running. If you're not running appropriately, can damage that plantar fascia. Now, PRP, actually one of the better, in my opinion, from what I've read, long term for any condition, PRP is incredible for plantar fasciitis. And it's interesting because usually in the beginning, when I first started learning about orthopedic injections, I learned from some other docs, and I was told to never inject in the bottom of the foot. Like that's what I was told. Just you don't do that. And so it's interesting now that PRP is associated with superior pain reduction and physical function compared to placebo and steroids in the long term for plantar fasciitis. And I believe they do a lateral, not quite a bottom, but a lateral insertion.
Oh, sure. Okay.
So I definitely understand that. But yes, it might be a little painful, but I tell you what, if you've ever had plantar fasciitis, you just know how grueling it can be and how long it can take to go away. Most of the time, if you aren't successful, you'll need to wear a boot for up to a year. It can be really cumbersome to manage this. If you are able to then use this therapy to improve, your outcomes, by all means, that's super, super helpful. Again, dextrose prolotherapy is even inferior to steroids, which I wouldn't even use steroids. So definitely not recommended as a first-line injection. Basically, what I'm trying to say, PRP is far superior to placebo and steroids for plantar fasciitis in the long term. Doc, anything patients should understand as far as tools for managing this condition?
Yeah, I think, and some of this I remember learning from you, God, probably a year ago or no. So in terms of tenting, so like when people say they had like bone spurs on the bottom of their foot, often due to, they had plantar fasciitis, but it worked itself out. But of course, the problem is still probably underlying because it raised the level of your pain reception, which when people say they have a high pain threshold, it's not necessarily a good thing because then it more or less diminishes the signal and there's still that problem there. So when I said tenting, actually, Doc, do you want to explain that?
Yeah, so
explain that a little bit better.
The way that I was educated on, for those, we can correlate bone spurs and fascial pain on the bottom of the foot together a lot of the times. I wouldn't say every time, but a lot of the time. What actually is happening, so a lot of people think you have been walking on your feet for so long that the bone spur starts to form, and then that spur can maybe dig into the fascia, maybe even cut it or cause any tearing.
With every step,
then we get the fasciitis and so on and so forth. However, the way that it actually works is over time with improper gait, maybe poor arch support, the fascia starts to become very taut and starts to stretch so much as that fascia is then associated or connected to your bottom of your bone, your calcaneus, your heel. It's so tight that it actually starts to pull off of the bone. And the space in between, like your shirt, if you were to pull your shirt off of your body, that space now is going to be filled with bone, if my body was the bone. So it'll start to pull. The bone then does not like that there's space in between tissue bone. It starts to then fill in with bone. And as it continues to pull, that spur is then formed. So when it's the chicken and the egg, it's, I just happen to have a bone spur there now, and that's what's causing it. No, your improper gait, how you've walked, how tight your foot have been is not managing that way is actually what caused the spur. And so that's actually preventable to a point. That's where you need to understand that it's not just, and yeah, some of it's going to be due to genetics, but there is more of a control in your own actions to preventing these kinds of things than you originally thought.
Yeah, I love how you describe that way better than I probably would have. So yeah, bone spurs increase stress of tissue over a long period of time, and then the bone adapts around it. That's not necessarily for every bone spur. There's different conditions that can lead to that as well, but really good points, especially off the heel. Now, in terms of therapies with this PRP, usually a good place that I like starting off with is connecting the nervous system to your feet, because a lot of people, like I'd suggest, and I I want you to try this if you're listening at home. Put your foot on the ground. Try to lift your pinky toe off the ground. Just your pinky toe or outside couple toes. If you are not able to do that, then there's there's definitely lack of connection of your nervous system there, which automatically is going to lead to compensation. And if you're walking automatically without control support, proprioception of your feet, a lot of times your feet are going to round inwards, thus known as flat feet or pronation. So how we can start about this is trying to lift your outside few toes up, 4 toes up, put pressure of your big toe down to the ground, hold that for about 5 seconds. Then switch, put pressure of your outside 3, 4 toes down to the ground, lift your big toe up. Go back and forth with that 5 seconds at a time, each one throughout the day, multiple times will help significantly. Now also, in addition to this, there's a bunch of other therapies that you can go about this, whether it's orthotics for a period of time with feet rehab and then work out of the orthotics, or start by strengthening the arches of your foot. So how you can do that is by gripping the ground, bring your foot inwards, outwards. You then can add on load, whether it's a barbell on your back, if you're at squat, and gripping the ground, and then try to absorb load on the outside portion. Bring your knees in front and round, so you can explore a little bit as loads on it. But when you first start off with this acuteness, I definitely want to get it under control. So that's where I'd start off. Outside 4 toes down, big toe up, big toe down, outside 4 toes up, back and forth. Connect the nervous system, and then work on gripping in different planes in terms of when you grip, what way does your knee go? And is it supporting your whole body weight, or is it just, are you seated, gripping the ground, and then moving your knee inside, outside? So those would be a few awesome places to start and a projection moving forward from there.
And this is what Doc meant when he talked about below the chain and up the chain.
Mm-hmm.
So when we're talking heel, ankle, foot issue, he's talking, okay, even for Achilles, when we talked about, that's what you could also be doing for below the chain.
Yep.
Not just for feet issues, because that again is what's going to help that entire process, that entire chain. So just so you guys understand where you can actually use those kinds of exercises as well.
Good point.
So next up we have rotator cuff tendonitis, super common, very common.
Oh God, yeah.
I think that's one of the higher amounts of research for PRP. Outcomes likely to provide superior pain relief compared to steroid injections for rotator cuff, which again, cuffs is mostly tendons at the end towards the insertion. So again, should never inject into the tendon anyway with steroids. So PRP for sure is a great therapy to have relief. Doesn't always cure the issue, but if we're looking for long-term relief without any degradative change to the tendinous area, PRP is a great addition. Doc, there's so many things we could probably talk about rotator cuff, but any quick gems?
There's so much with the shoulder. The shoulder is very complex. I think there's a few things to pay attention to. If you've had any past shoulder problems, whether it's overuse or throwing objects or past injuries, if the pain goes away after a period of time, you still want to be very cautious of that. Or let's say you had an injury in the past, it worked itself out, no pain now, fine, but maybe I just don't have as much range of motion. There's still probably that underlying problem there.
Yep.
And more so what I'm talking about is, especially for a lot of people that don't think in terms of how the structure can affect function, the outside portion of your shoulder, the acromion process, for a lot of individuals with chronic overuse or any shoulder conditions, a lot of the times that acromion process, that bone on the outside of the shoulder, starts to dip down, which then can lead to bursitis, a bursa problem because of lack of space from your upper arm bone and the shoulder. It can also lead to the shoulder, the humerus, brought forward in the capsule, leading to posterior anterior capsule symptoms. It can also lead to tendinopathy at the bicep. It can lead to pulling tension from the shoulder to the neck. So I think that the biggest gem there, if you've had any past injuries, but you don't maybe have the range of motion, but the pain's not there, you still want to work on some of these rehab therapies. So then I would suggest going back to our shoulder podcast. and or just getting it checked out by a medical professional. Even if they say it's okay, good, you probably want to find someone that can dive into this area a little bit more, or know a trainer, whether it's a functional range conditioning specialist, that they can dive into certain specific tissues and different properties of that shoulder itself.
Yeah, and yeah, that's awesome. The only thing I want to add is what Doc was saying was, for dissecting what issues you have, pain should not be the primary thought process. It's function.
Good point.
And so Doc is what he's basically driving home is, you need to take a look at how functional all of your joints are. And when talking to the shoulders, it's again range of motion, strength, the things that matter. Yes, pain sucks, but pain is usually the last thing on our minds, and it should be the last thing on your minds. It's, can you move your shoulder through a full range of motion? Are you able to lift the same amount of strength you have when you were younger? All these things that are super important. And if we don't have that moving forward, it's only going to continue to progress and get worse, which then comes a point of you're in your 50s and you're not even able to clean your yard or lift your arms above your head to cut hedges, or even all the things, put boxes above your head, like things that you're like, oh, I'm going to be able to do that still. No, we still see a lot of people who have to give up those kinds of things because they're in so much pain, and that's a worse pain. So
yeah, good point, Doc. Thank you for bringing that up.
Yeah. Next up, we have knee osteoarthritis, which knee osteoarthritis is the most heavily studied condition for all biologics. This has been studied for many years. It's got a great amount of research. PRP is associated with superior long-term outcomes compared to HA, hyaluronic acid, which is just a gel substance that is found in the body. HA is found in the body for many joints and other things like that, skin. It's superior to HA, corticosteroids, and placebo. If I were to start out with any injection on the knee, it's going to be PRP.
Nice.
By and large, very helpful. There is still inconsistent evidence for stem cells in the knee. PRP is favored because of just how much more research there is. However, I have still found great outcomes with stem cells if you do it right, and do it right is the caveat there. So I'm not going to get too much into it, just because we'll get to that later. But yeah, great therapy for this condition, and people should definitely be doing it.
Yeah, good point. One other thing to add into knee osteoarthritis, this is where we're seeing a lot of practitioners recommending surgery for individuals where they don't necessarily need it. And
for sure.
so if you start getting the recommendation, you go to a doctor, you don't know where to go, they recommend that surgery is needed, but maybe now is not the right time, but it's inevitable down the road. That phrase itself, you want to get ahead of this. Find a practitioner that can work on the knee muscle tissue wise, but that is where you want to start working on different types of tissues. Now, if there's a practitioner that, let's say you are in a small town, don't know where to go, there's limited resources, start off by rotational work first. So whether it's putting pressure of your heel to the ground while seated, without moving your femur, upper thigh bone, bring your foot outwards and inwards. That rotational work will start pulling tension not only on the MCL, LCL, the ACL, just to stiffen up those ligaments specifically. It will also help for rotational work when you bring your foot outwards. It helps bring a little bit more blood flow to both inside outside edges, and then you can work on terms of building up the rotational capacity. From there, because we want to start with the deeper structures first, that's why we start rotational work. From there, you then want to go to building up knee flexion, extension, work on either slowly lengthening the leg or slowly bending the leg. Depends on where you want your focus to be on, and that's, again, going back to eccentrics, bringing a joint from short to long. So then you can work on different specifics from there. Usually a good way that you can start going about this, once that pain, discomfort starts dying down, backwards walking does really well. When you do backwards walking, focus on pushing off of the heel while your feet are straight in front of you. And/or when you walk, just noticing pushing off, landing on your heel, pushing off of your toes, especially off your big toe, because if your feet go outwards, you're then going to be jamming, especially for females with wider hips, naturally for childbirth. It leads to more pressure on the inside portion of the knee, which then affects the meniscus and or nearby structures. Then the breakdown of joint space then occurs from there. Whether it's redistributing pressure outside portion of the knee to redistribute space, but then going back to the point, focusing on bottom up, heel, foot, backwards walking, and or bending the knee, straightening the knee, rotational work, top down, quads, affecting the knee. So there's a couple different things that you can start working on from there.
Perfect.
Yeah.
Perfect. We have a hip OA next, and with hip arthritis, it's a different kind of joint comparative to the knee, but it's still PRP still showed certain improvements in pain and function. They actually have studied HA injections in the hip too, which is interesting. They're starting to experiment more with HA injections outside of the knee, which is they've done it in the shoulder. I think they've done it in the hip. But yeah, intra-articular PRP may lead to improvements in pain and function, but there are some studies showing that it's not too different than HA injections. And why that's important is because PRP isn't quite covered by insurance yet, whereas HA, I think, is starting to become more covered. So it's just a matter of if we're getting the same outcomes, and then again, you don't have to pay out of pocket. Obviously, that's super beneficial for those who can't, afford it at the time. More research, I think, is needed to show what is better, but both lead to similar outcomes comparative. Doc, anything with the hip?
I'd say a good place to start, there's a lot of different things that can be involved with the hip, but going back to hip workspace, moving the hip through the biggest range of motion possible, especially when you bring your knee bent, leg outwards, and work on rotational work. If you notice cramping, it's not a bad thing 99% of the time. So if you take a break, go back into the motion so you can bring blood flow to the edges of the joints. There's a bunch of other things that you would probably want to go in with that one, but mixing in with PRP, that would probably be a really good starting spot.
Perfect. Perfect. Shoulder OA next. And shoulder OA more than likely comes with rotator cuff issues, probably. Similar. So this is going to be similar. However, when they specifically studied when there was osteoarthritis involved, it did have a long-term improvement compared to steroids. And you're going to see that time and time again. PRP just is a better long-term approach to treating an issue, which that is what should be in your mind when you're thinking about how to manage an issue. It's, yes, steroids may be in the short term. Sometimes PRP is actually better in the short term too, comparative. But yes, you're going to get that relief, but that relief sometimes only lasts a few days. And what's the point if you're already getting that breakdown in tissue? The sacrifice of the health of the tissue for a few days worth of pain relief just doesn't equate.
And we had a patient too that they got a steroid injection, didn't help, and now he wanted to get surgery. They has to wait for the surgery because of
risk of infection. That's right. And I just don't ever see a need for it now. If it's really bad and it's gotten to a point where it's actually affecting their entirety of their ADLs in their life, yes, then steroids is a good, quick, cheap way to get some pain relief. But there are other better options out there. There really is. So yes, shoulder OA, PRP is associated with longer term improvement compared to steroids. Doc, with the shoulder, anything else we didn't touch on?
There's a lot of stuff, but you guys can go back to some of the stuff we just already talked about, rotator cuff aspect.
Perfect. Next up is low back pain that has been, or that the pain is mediated from the facet joints. Very quickly, with facet joint low back pain, you'll have radiation down the butt, maybe into the back of the thighs, but it doesn't go all the way down the legs as would sciatica. So that's where the difference is. And it showed that PRP was associated with superior pain relief and physical function compared to steroids. And it usually, there isn't a lot of providers who can maybe do a facet joint injection. They're usually an orthopedic surgeon or a pain management doc. So you might have to go to a clinical setting where they do more surgical focused injections. But I used to do, for low back pain that came from the facets, we would do parafacet, which was just outside of the facet, not actually in the facet, and we found to have good outcomes anyway. But yeah, for those that are interested, it can absolutely help with low back pain, especially if it's coming from the facet compared to steroids.
The one part I want to add in with the joints, especially of the lower back, and I'm sure the PRP and not only the lower back, but probably throughout the whole spine is probably very similar in terms of the results. However, as the PRP goes in, I wouldn't do this the day of getting the injection, but being cautious a couple days afterwards and slowly working it in. We want to create glide in the joint. So a lot of that will come from different types of movement, specifically joint-related movement of the lower back in terms of this case. So when you go into it, and usually with these type of injections, there's often other problems that could be related, whether it's discs going back into the spinal canal, or the narrowing of the spinal canal itself in terms of stenosis, or as the nerves go out of the spine and outwards to the body, there could be narrowing of the foraminal canal. So there's a couple different things that are usually involved with that. But a good place to start, and this usually comes even with pain relief itself, is by going in sharp, pain-free, ideally, type of motions. For the lower back especially, with how the joints are set, almost like a forward and backwards type of articulation. Bringing your body back and forth to create the glide, but the focus should be on any of the area of target. So for example, for the lower back, lumbar facets, forward to backwards movement with a little bit of tilting, which will help for the glide of the joints on each side. One, to open up the opposite side in which you move, but then and where you're tilting, the near side, it also create a little bit more pressure and friction. When you first start off, just work on flexion extension. As that becomes easier, then you can add in the tilting from there. But that'll work really well.
Nice. For SI joint pain, this is pain that is not quite middle of the back, like low back. It's maybe off to the side around the upper buttock, and that could be on either side. Even sometimes it can radiate maybe down into the lateral hip, maybe even underneath the glute, possibly towards the posterior thigh. And it's usually one-sided. Sometimes it's both, but usually it's just one-sided. And with SI joint pain, even within, this is just for PRP, but there are a lot of other studies with certain injections for SI joint pain, and it has variety in the outcomes. So right now, I would say there is still a lot of research being done on how to appropriately manage SI joint pain. Some of the people that I follow, they have their flow chart of how they would manage SI joint pain versus maybe a modern medical. The modern medical route is 3 diagnostic injections of an analgesic like bupivacaine or Lido or something like that. And then if that helps, then they'll do either if it doesn't work, I should say, then they go and do a fusion. And that's where they're at right now. We do injections. If that doesn't help, then we go right to an SI joint fusion. That's, in my opinion, a very quick progression in invasivity.
Right off the slope.
Yeah. And anytime we fuse a joint, we're already then putting more force above and below the chain. We've talked about that. So you want to make sure, I don't know about outcomes of fusion of the SI joints. I think we still are learning a lot more of outcomes. Yes, maybe in the short term it helps with relief, but what are we getting long term? Just we're trading off a lot of force change into different parts now above and below. Next thing, your low back is now being wore out quicker because the force cannot be distributed appropriately. So something to think about if you are having those issues, or if you're even having a conversation with a provider about this kind of thing. So it showed that PRP may be superior to steroids, but it's still a little inconclusive. We do SI joint injections here just for pain relief usually, but there's so much more that I think you can do away from injections, especially fusion, way before the issue gets worse enough. Doc, SI joint pain, how do they manage that appropriately?
Yeah, that's a good point. And going back to the point to where an SI joint is fused, especially if it's only on one side, there's a patient we have now that managing that case is incredibly complex. Going back to Dr. Addy's point, it'll lead to compensations usually above or below, especially for SI joint. It's going to lead to either stenosis into the lower back, facet problems, lower back. And then every step that you take, and this will lead into the point I'm going to talk about when using PRP with therapy afterwards. But every step that you take, the pelvis rocks side to side, and it allows shifting of the tailbone with every step, which again, going back to some of the injections we use not only for pain, but also for that rocking, tilting motion. So if a bone is stuck out of place for a longer period of time, people might notice pain coming for a while, for a few days, and then the pain might settle, especially if it's like lower back glute area, like Doc said. So it's creating glide in the joint. Now, a couple ways that you can go about it is by moving specifically the leg while stabilizing the lower back, but by moving the leg forward and backwards, a marching position, and then extending back. You might have to also work in terms of standing on one leg with a support system, holding onto a wall, stick, what have you, and bring your legs inwards and outwards so you can then either force the rocking of the tailbone SI joint forward and backwards, and or when you bring your leg back inside the outside, it will also help that glide as that tailbone is in different positions. So you can almost get your tailbone unstuck from the outside pelvis to the tailbone or that SI joint.
Yep.
But that would be a good place to start. So
And you're not able to do that when it's fused. You don't have any movement.
it goes
And
forward back.
that's what's so crucial when managing this issue, is being able to improve the glide. As we age and as maybe more wear and tear has happened, that joint has probably gotten less and less in space.
Yep.
So those exercises are still crucial for a healthy SI joint. And when you fuse it, we don't have that ability to improve that now. Thus, force being put somewhere else. I'm going to go out and say, in my opinion, I would try absolutely everything before you try fusion.
Oh, God, yeah.
And when it comes to injections, long term, it still may not be the right choice. Instead, go for the management of movement therapy, stimulation, mechanoreception, and exercise for sure to help with that long term. Lastly, for PRP, we have discogenic pain in the low back, or really any vertebral space. For disc-related pain, if there's a bulge, if there's herniation, or if we have degenerative change, you'll usually see one or both-sided radiation, possibly all the way down the dermatome, which is either into the fingers, hands, feet, toes, those kinds of things. And it can be very sharp, very painful. There might be tingling, numbness associated with it. You might have weakness, and it's not a fun condition to have, especially with its limitations. With PRP in specific, it can improve pain, but there is little evidence to show whether or not it's helpful due to variations in PRP formulations. In all biologics, we're still trying to figure out how to manage disc issues. And the reason why is when you inject straight into the disc, it can come with certain outcomes, such as discitis, or like a small grade infection of the disc after you've put biologics near it. The ones who are doing it appropriately are knowing how much, when, where, how, and trying to limit any negative outcomes from a disc injection. But if you're going to inject into the disc, there are probably not that many providers that truly know how to do it so that the outcomes aren't negative. If you are going to look to do it, make sure they've been doing it for years. They know how to manage it in the short term, the long term, what to do, because injecting into the disc is very invasive and there could be some outcomes that are negative after that. Would I recommend it based off of this report? Evidence is inconsistent, and I may try other things, such as maybe what Doc is about to say coming up, managing disc issues.
Yeah. Before I go into that, because I know a majority of medical practitioners, they only have so many tools in their toolbox, so they usually go the steroid route for discs. Do you want to touch on why that's not a really good idea?
Yeah.
Injections for disc.
Yeah, for sure. You're going to have. But yeah, actually, great point. That's a great point. I was fortunate enough to attend a seminar where I got to see some preliminary research that hadn't been showed to the public on what corticosteroids do to the actual disc itself when it's herniated. And so we were shown pre and post MRI of injections of steroids for a disc issue, especially if it's herniated. And what they showed was, back up quick, when we have a herniated disc, some of the disc has leaked out into either the back lateral portion of the spinal column. Sometimes it can go straight back, but usually it's just lateral too. And that's where the nerves come out of the spine. So that's why when a herniated disc pushes against the nerve, you feel that numbness, tingliness that we associate usually with sciatica or radiculopathy. And it takes the body about somewhere between 5 and 6 months to actually eat away the jelly-like substance that have leaked out of the disc and resorb it back to where it needs to be. And the body does that by itself. When we have these issues, yes, we want to make sure that as providers we can help you in the short term manage the pain, but a lot of it is done by the body after about 6 months, and so we're just helping that process along its course. But when we take and we inject steroids into that setting, it actually freezes or stops the healing process. So now your body is not eating away that nucleus pulposus, that jelly-like substance, and you're basically shutting off the inflammation part of how we heal. When we hear inflammation, we always think it usually is negative, but when we heal, inflammation is that process, and that's exactly what happens. So with steroids, cuts it off, and we were shown about 6 months after steroids, the disc was still frozen in place and there was no resorption of that herniation. So
That's constant pressure on the nerve.
Yep.
That's constant pain, not
and now you've shut off that process, and that pulsus is more than likely either hardened or it just is not resorbed back into where it's supposed to be. So that's where PRP can be helpful, because it is a pro-inflammatory therapy and it can maybe reignite that healing factor. Just things to think about before you, and I know it can be so painful and you're just looking for some pain relief, and that's where the steroids are going to be helpful. But I would fight fire with fire, add PRP in with it so that the healing process is still happening, and then just managing the pain with a provider who knows what they're doing moving forward. Doc, anything else with that?
So the one thing in the back of my mind that's so common that not many, it's either providers know or the general public definitely not. So a few things that you can start to aid in bringing that disc in back to the center. If you guys are watching, if you can think of two bones in your lower back, one on top of the other and a disc in between, what Doc was saying, if that herniation goes back into the spinal canal and pinches off on the nerves, how you can get that disc back into place in addition to just it naturally reabsorbing itself is by extending backwards more times than not. So whether it's you're laying on the couch, bed, and you push your upper body up to the ceiling, so you're extending your back, holding for a few seconds and then back down. Depending on symptom-wise, it's more times than not very comfortable, which that's why you want to go a few seconds at a time. Over time, that'll accelerate the healing process. But when you first start off with this, you first want to be diagnosed with a disc injury. That's from a medical practitioner. And then you can start on some of these therapies at home. So when you going back to extending, pushing your upper body up off the bed, extending your lower back while laying in a relaxed position. You can also push up and then tilt your body right, hold for a few seconds, back to center, left for a few seconds, back to center. So it can also help bring more pressure on the back angles, a little bit more specific. As that pain starts to subside, things become easier, then you definitely want to go through and move the joints to the biggest range of motion possible. Very easy, not moving to sharp pain. So what I mean by that is going through lumbar, workspace, spine, cars, whatever you want to call it, by moving through the biggest range of motion possible, especially extending backwards, being very cautious, coming back around both directions. 3 to 5 times, nice, light, easy, multiple times throughout the day.
And a small tidbit of kind of cool outcomes that we have had with patients that use that tool to help improve their low back pain. Doc, I know you showed me an x-ray of one of your patients the other day.
Cool.
This was a patient that I don't believe did any other additional therapies like in PRP or anything like that. It was straight just exercise, PT at Chiro. And this patient had narrowing of the lowest vertebrae disc space. And after a few months,
L5S1, I think.
Was it a few months? Maybe even a little bit longer?
I think it's 4 months.
4 months.
Yeah.
In that, you want to maybe just explain a little bit of her therapies that she was doing, and then what the outcomes were based on the x-rays post.
Yeah, that's a good point. And this individual, she also came in with other problems as well, but this subsequently helped for some of the lower back pain that she was having. That was part of it, but when she was going through some of the therapies, we wanted to isolate We'll get all the joints moving properly. So that's full body workspaces, moving all the joints clockwise, counterclockwise, fullest range of motion possible. So you can bring blood flow around the edges of the joints.
Yep.
From there, we added in some trigger point therapy, probably a little bit. I can't remember if she had SI joint trigger point injections or not, especially for bupivacaine. So that helped ease up the rocking of the tailbone, which also helped for blood flow to the L5-S1 disc. So naturally, it helped for the healing aspect. So it was a mixture of trigger point therapy, SI joints. It was specific rehab workspaces, a few other things in terms of a wobble chair. And wobble chair is more or less a chair that you sit on that can move, so you can move in different positions for rotational work of the pelvis on top of the lower back. And then there's some massage therapy work, some chiropractic adjustments. So all that considered, I think on the front portion, if I remember right, I'll have the picture up. So these numbers that I'm saying might be a little skewed, but I believe the front portion from the L5-S1 disc was like 8 millimeters in terms of disc space, and the backside, I don't even know off the top of my head, 4 millimeters of space or so.
And you'll see those bones are closer in margin than maybe other ones in the spine. And you can compare and see just how much space she had lost.
And then it increased significantly from, I think it was 8 to 9 in the front millimeters of disc space to 11 millimeters. And then the backside, God, I'm probably off on these numbers, but anywhere from 4 or so millimeters on where the spinal cord is. And that increased, I think, 6 to 8. So it pumped the disc up. So when people say that if the discs can break down over time, that you can stop that degeneration, that's part of it. But you can also pump up the discs, and there is specific proof for that.
Yeah. And the word that we use is called imbibition, which is just, again, the doc said pumping, as we're pumping the disc itself, trying to provide nutrients and blood flow into the disc and allowing that to then hydrate. As that hydrates, it increases the space, which all around, we don't even have to explain it that way, but you guys should know that when we have more space, there's going to be less chance of compression, changes in the nerve outcome, all those things. But
and naturally, some of this stuff, like when you lay down and sleep, like in the morning, the disc naturally hydrate a little bit, maybe not even a millimeter or two, but as the day goes on, because of gravity, the disc compresses a little bit. So naturally, it does it itself, but with certain therapies, it can increase it significantly.
And I had never seen anything like that before, and I was astounded because that is impressive. That is so cool.
And actually, sorry, the one thing that I want to add in, Doc asked like when the images were taken, and it was at like 6:30 or it was like 5:30, something. It was in the afternoon at night, and the images pre and post were taken around the same time, within a half hour.
And I asked that question because of the whole, what Doc just explained, the hydration effect. It's okay. Was it more hydrated at a certain part of the day, thus meaning the x-rays were going to be a little, but no, it was taken at pretty much the exact same time of the day, pre and post, 4 months. That was such a great case study. Such a great case study. Yeah, super, super
Perfect.
cool. So that was PRP for all those conditions. Definitely going to be the most studied intervention when it comes to these injections. We're going to move on to stem cells now, which I'm going to go through relatively quick because the outcomes are pretty much the same for most of these conditions. I might touch on a few things here and there. And I wish I had more to give you, but based on this report, and if you look at the body of research, we just still have a lot of work to do when it comes to stem cells. But I might touch on a few of my clinical experiences, just so I'll leave you guys with some gems. What they looked at, again, lateral epicondylitis, rotator cuff, knee OA, disc issues, and spinal cord injuries. There is pretty much across the board just limited evidence that suggests it may improve pain and function in all of those. That's just going to be the kind of the consensus. So I'm not going to touch too much on each of those. It's still limited. Definitely go by what your provider has done clinically and as far as their experience. Have them tell you what cases they've had and how many patients they've treated. I hope that they're being honest when they tell you that. I definitely have treated way more, like let's say, for example, knees than say maybe I have shoulders or hips. So when I talk to patients, I just use that as far as my experience. And with that's what I wanted to touch on as far as knees. It does say that in this report, evidence was conflicting. Some suggest that stem cells may improve pain and function, but again, results are inconsistent. I know that there is more research that shows PRP is favored over stem cells just because the evidence is stronger for PRP. But I have found that stem cells are incredible for long-term outcomes for knee issues. So I have no problem recommending stem cells for knee issues. Comparative to maybe hip or shoulder, there's still some outcomes that we would need as far as the research goes. That's what I would leave you there. The other thing would be stem cells in the short term usually is not as effective as maybe some other injections, but the long term, I've found that function improvement, especially in the knee, cartilage regrowth, strength, all the things that we're finding long term, it's such a great addition and benefit to outcomes. That's where you got to think of stem cells. It's not something that's just going to go in right away. Pain is going to go away quickly. Although, not to say that we haven't had those outcomes, but most of the time I'm preparing my patient to say, when we're putting stem cells in, it's going to take some time for that process to occur, and you're going to need to give it some time for the body to do its job to start to rebuild the cartilage, especially in the knee and wherever else you're injecting. But yeah, long term, I love it for knees. I've used it in hips, I've used it in shoulders, I've used it a lot of other places intravenously, but I'm not going to get into that. But yeah, I love it. More research needs to be done, but yeah, it's super, super effective for certain things. Doc, is there anything you wanted to touch on in your experience?
No, I think if you guys have seen some of the other podcasts, you have a decent understanding. But if not, with stem cells, not only for tissues, it'll help with long-term aspect, but even for cognitive, mental processing, and even just certain neural circuits in the brain. It also improves the connections there, and a lot of other properties like psychological, mental wise as well too, that not many people would even thought of.
No. Still so much to be done to show. We did a great job of breaking down kind of the safety and efficacy of certain injections, I think, with one of our Regen podcasts. So you guys can look back at that. The next one is bone marrow. It's similar. There's a little bit more research with bone marrow and adipose than just umbilical cord stem cells or donated stem cells. That's definitely leading the charge for research. So bone marrow and adipose. I think right now they just came out and said that adipose tissue, when spun down, is gray in terms of injection types. I know that there might be some clinics that were doing adipose tissue centrifuging to inject back, or are thinking about maybe holding off on that now due to the FDA's recommendations. But if you are interested more in adipose tissue, just look into that. But bone marrow, by and large, is definitely the more commonly used route for sourcing your stem cells, which is harvested from your bone marrow, which is a painful extraction, so just be wary of that. But the things that they touched on, again, were epicondylitis, rotator cuff disc. Basically, it said that there's limited studies, but could have outcomes just based upon the research that was shown. But I definitely would say that with the providers that I follow, the ones that are leading the regenerative medicine charge, a lot of them are using bone marrow and they're finding good results. So just making sure that you work with a provider who's been doing it for a while. Doc, anything with BMAC?
Oh, I don't know too much clinical-wise, so I can't touch on that.
Yep, no worries. Next up is Prolotherapy, and Prolotherapy uses dextrose water. Dextrose is at a 6-carbon chain. We just looked that up to stimulate tissue repair. And now there's still some inconclusive understanding of how Prolotherapy works. A lot of the hypothesis is just due to the fact that there's the theory of how the 6-carbon chain reacts with our tissues, and it just provides for better communication and healing. And then there's just the hypothesis of when you shoot solution into a trigger point area or an area that has maybe fascial thickening or stickiness, I guess is maybe a not so medical term, but when that solution is pushed into that, it frees up that fibrotic area and it can allow for better movement, less pain, better communication. And it's also helpful because it's not lidocaine, bupivacaine, which again can have some degradative nature. It's not as bad as steroids, but it's just a matter of preference, usually, I've found with providers. So some providers only use Prolo. Some providers are okay using bupivacaine and lidocaine. I don't think there is a real big difference. I used to use Prolotherapy a lot, but I switched away from it. I found that there was things that were more effective. But what they found was the three things that they actually showed some helpful outcomes, which would have been for lateral epicondylitis. Prolotherapy shows comparable results to steroids, but we also found that PRP was superior, so I would have just used PRP. Same for plantar fasciitis. Actually, Prolo was inferior to steroids, and it wasn't even recommended. And then other tendinopathies, it may have effects on tendinopathies, though it's still experimental. Prolo, it's definitely one of those that was good at the time, but I think there are now better outcomes using PRP or other things. Doc, any experience with Prolo?
Not too much. Sometimes if you hear getting trigger point therapy injections, that sometimes this can be in that same type of category, which can help significantly, much like Doc said. I like how you put that, removing that stickiness of the fascial plane. Like, that's a really good analogy. Yeah, I think it's a tool in the toolbox, but for certain things, so going back to some of the epicondylitis, so like the lateral epicondylitis, instead of steroid, I myself would rather go prolotherapy than steroid because of the steroid breakdown.
Good point.
So it's, and that, more times than not, Prolo will probably be covered by insurance instead of PRP. So if you want a cost-effective route, I'd go prolotherapy instead of steroid injections.
But you're
Not
also
on plantar
trading.
fascia.
But you're also trading efficacy too, and
Exactly.
it stinks. We would love for PRP to be covered more often than not, but
Yes.
it's tough. It really is. We get to adipose-derived cells, which I just talked about. It's where they use a liposuction type of mechanism to extract the fat, spin it down, and inject it. Really, the only two things that they showed was for knees, inconsistent. Some suggest benefit, results are mixed. For spinal cord injuries, it's still limited, but it's not recommended for spinal cord injury just due to lack of data. Again, with adipose, there's still just not a lot of, and stem cells in general, there's not a lot of research, so there's just more that needs to be done on that. Kind of a summary for you very quickly. PRP is superior for long-term relief in lateral epicondylitis, plantar fasciitis, rotator cuff, and knee OA. MSCs, BMAC may offer benefits in discogenic pain, lateral epicondylitis, though evidence is less consistent. Prolo is not the first choice for most conditions like plantar fasciitis, where PRP is favored. So that was such a great overview. Very, I think, covered a huge amount of questions that people would have when choosing this, when choosing these interventions. So the last part of the research study that they did, which was, I love this, is they asked 15 key questions, and we're going to just go through those really quickly to help. And a lot of these might be redundant, so we might just go over those relatively quick. But yeah, the key questions were, what are the key types of injectable biologics? And again, they focused on PRP, stem cells, which is BMAC, donated ACS, and SVF. And the consensus was PRP is superior for most musculoskeletal conditions, but more research is needed for other stem cells. So again, just be cautious of that. We touched on what is the evidence supporting PRP and lateral epicondylitis. Absolutely superior to steroids. Can it help with medial epicondylitis? It's limited, but it does provide way more relief than surgery or surgery on the tendon. Is it effective for rotator cuff? Absolutely. It's better than steroids. Is it helpful for plantar fasciitis? I would say not only is it superior, but it's one of the best for any condition. Yes, it is. It's so helpful, especially comparative to steroids and placebo. What is the role of PRP in knee osteoarthritis? Superior to not only HA, but steroids, and should be, in my opinion, one of the first injections that you choose for your knee.
So true.
How about stem cells for treating the knee? It's conflicting. Some studies show benefits, but it's inconsistent. It's not yet recommended over PRP. However, I would put both of those together. When we did knee injections, I used PRP and stem cells at the same time for most patients.
Oh, okay.
Yep.
Smart. Long-term and short.
Yep. And there's not many studies showing the combination of PRP and stem cells, though the providers that I've worked with and just the people that I've learned from, both, they have a synergistic effect.
Okay.
And the ones that are combining are getting better outcomes, and that's what I chose to do with the patients that I had. PRP for shoulder OA, absolutely better long-term relief than steroids. PRP for SI shows better pain relief compared to steroids, but again, injections, a touchy area of research. Definitely resort back to what we were saying earlier in the podcast. Does it help with lumbar pain, facet pain? It absolutely can. It is recommended, but we actually, it's a tough area to inject, and it might not be someone, you might have to search to find someone who's comfortable doing facet injections. Is it helpful for Achilles? No, it's conflicted. We would rather you do eccentric work, like Doc was saying earlier, probably for the long term than to inject in that area. What's the difference between PRP and stem cells? Right now, there is no direct significant difference between PRP and stem cells for knee osteoarthritis, but PRP has stronger evidence for most conditions. Discogenic pain can improve due to PRP, sometimes BMAC, but again, it remains inconsistent for stem cells. Is Prolo recommended for chronic pain? Some evidence supports it, but it is inferior to PRP and it is not recommended as a first-line treatment. And then can it help with neuropathic pain, which is what I wanted to end on today with what I actually saw in clinical experience. PRP can improve things like diabetic peripheral neuropathy, but evidence is limited. What is neuropathic pain? That is coming from an altered source at your pain receptors due to central sensitization. How the nervous system is being affected is now altering how you're perceiving pain. So for example, your threshold of pain is changed. So what should be felt as normal pressure is actually being perceived as maybe more pain than just a gentle touch. What's happening is there is, with, for example, neuropathy, there is a breakdown of the nerve endings, and you're having more and more pain due to that, that disease or breakdown. What we actually would do is we would take PRP and we would inject it into the areas of pain at the feet and legs, and it was showing great outcomes with this. And so we absolutely recommend doing this for those who are struggling with neuropathy. If you've tried other interventions, still you're going to need to manage blood sugars, lifestyle interventions. You got to have better diet. You got to move. That's going to be first line. But if you're still having issues, it can absolutely help patients with neuropathic pain.
I love how you explain that too.
Yeah.
Made a lot of sense.
So yeah, that is the general and very, well, I should say broad scope, but also specific breakdown of all the injections and for each condition. I loved this study. I thought this was so helpful for everybody who needs this, the nitty gritty of, okay, this worked for this and what should I choose first line? And so hopefully this was super helpful for you guys. Hopefully we can get you guys some more guidelines coming out maybe in the future for exercise and other interventions too, and maybe do a deep breakdown. Doc, anything else to leave the audience before we conclude?
No, that's beautiful. As always, like, subscribe, share. Anybody that has chronic pain or discomfort of any sort, share this with them. They'll give them a good understanding, even for them to bring this podcast to the provider so the provider can watch it, because a lot of this stuff, it's newer research that not a lot of medical practitioners are able to keep up with just in itself. So it's a good overview study with a bunch of studies added into it that gives us a better understanding of where some of these regenerative medicines can help with.
Yep.
So strongly recommended from there.
And for providers, what to refer out for which conditions too. Some providers don't want to take on adding these therapies to their clinic, and so they would just much rather prefer. And so this is a great tool for them on which conditions are best for referring out and using these interventions. All right, everybody, thank you so much for watching. We'll see you next time. Until then, Doc, you guys have a great day.
Disclaimer, the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on the Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.